Thank you, Michaela. I am recording now. Let me back up to say a few things really quick since I hadn't hit record. Thank you very much. When we talk about airway diseases, upper airway, lower airway, upper airway pertains to the larynx and the trachea. The main issues can be trauma, edema, which causes swelling. It can be a tumor or a foreign body. Now, say a dog swallows a corn cob, a rubber ball, like I just explained. Any of those can get lodged in the airway. Or they can have this congenital condition, which is laryngeal paralysis. And typically what happens in laryngeal paralysis is that the nerves, innervation means nerve supply. So for some reason, there is a disruption in that nerve pathway to the muscles. What the muscles are supposed to do is the arytenoid cartilages and the vocal folds don't move themselves. Okay, so you have vocal folds, arytenoid cartilages, and you have the muscles behind. The muscles contract and relax, and they open those structures. So this is typically a nervous system muscle issue, and most of the time it's just a congenital issue with, or it's acquired as they get older. So if we look at the next slide, here is the arytenoid. So right here, see these little strips down here, those are, yeah, Sarah Callahan, I didn't have you down yesterday, and I had an iPhone, so I marked you as present because I figured it was you. So I was wondering if that was you. Okay, and we're good. If you look, this picture, arytenoid cartilages are up here. These are the vocal folds. Behind that are the muscles. So you're not seeing the muscles in this picture. But what's happening is these are not opening. Bouvier de Flandre, Dalmatians, Huskies, Rottweilers. It can be congenital in those breeds. Acquired, I'm going to say, if I look back to almost every laryngeal paralysis case I saw, it was always an 8 to 10-year-old Labrador Retriever. I mean, that's just an informal representation. Let me go ahead and show you this video. Hopefully you can see this on the screen. Now, obviously, this looks like a little pitty, so not our typical Labrador. I mean, you know, any dog can potentially get this disease. One thing I want you to focus on, and this is going to become important in anesthesia because I'm a stickler on respiratory stuff, is I want you to watch how this dog breathes. There is something called work of breathing. How hard is it to breathe? How hard are they working? Okay, anytime you get a lot of abdominal movement on inspiration, that's part of that inspiratory stridor. It causes increased inspiratory effort. And then most of the abdominal muscles are just to exhale. When they start using their abdomen to inhale, that is indicative of respiratory distress. So if you watch this video, right there, you can see that abdomen.
That's him breathing in.
So if you look right here, okay, now whenever there's airway videos, this is so difficult. You can't open their mouth super wide, so no video is super great. But if you look back here, okay, this is a laryngoscope, and they are pushing down the epiglottis. Normally, the epiglottis would cover that opening right there. Can everybody see that okay on the video that I'm showing? I just want to make sure that everybody can see this. If someone can just let me know. Okay, good, thank you. So what's happening, what we do when we do a laryngeal paralysis exam is we give a little bit of anesthetic, enough that we can open their mouth, but we don't want to stop their breathing. And what they're looking for, you're saying he's going inhale, inhale. Somebody is watching breathing and the doctor is watching the vocal folds. Now what's here is they are not opening wide enough, and that's why you're getting that loud respiratory sound. So let me go back a moment.
and breathing in, in. They're not moving.
As big as that feel, buddy. Oh yeah. As big as that feel, buddy. Oh yeah.
Hang on 1 second. Okay, I had to find a good place to pause it. And this dog, if you look back here, this is a good picture, okay? These are the arytenoid cartilages, and that is the epiglottis. And you can see when that dog inhales, they are not opening. So this dog is, and this is a different dog, that has a complete collapse, which would be an acute emergency. Now, this dog, you can put an endotracheal tube in there right now, but the dog can't live with an endotracheal tube in. So we're going to talk about what you do for this case.
They're not moving.
As big as that feel, buddy. Oh yeah.
So there's the endotracheal tube. So that dog is getting some air out, but they are not getting air in efficiently. And again, the other dog that was tubed, that's only that's only a temporary solution until they can decide on a therapy. What's going to end up happening, and that is a nice opening. You can see that that other dog's was kind of compressing it in that middle there. Okay, so there, and this is a great shot for when we go over intubation and anesthesia. That's where the endotracheal tube's going to go. Okay, so that's how we intubate. So what do they see at home is this, you know, the stridor is that sound, that stridor, and, you know, but an owner is probably not going to call it stridor. They're just going to be, they breathe really loud. Exercise intolerance because they cannot get air. Now, if you catch this early, exercise intolerance typically means cardiac or respiratory. Okay, so once they're not exercising like normal, we have to determine the cause, but they get a lot of gagging, especially eating and drinking, and dyspnea. So difficulty breathing, extra effort when they're breathing. Why would these animals be hyperthermic? Anybody wants to type a probable response? They often present hyperthermic. Potential. Exactly. They cannot pant. They can't exhale air properly. Inhale, exhale. So what happens is one of the first things we do in these cases present is you need to get a temperature. You can't always feel a dog and say, oh yeah, they feel hot, because I've had dogs that are hyperthermic and they touch and they feel normal. So just touching a patient is not going to be 100%. Get a temperature. I mean, obviously getting an airway and oxygenation is number one, but somebody needs to get on a temperature so we can make sure if we need to cool them. In severe cases, potential collapse because they're not getting oxygen. They're going to get a lack of oxygen to the brain and they're probably going to pass out. Severe respiratory distress. So if I ask you, what is the very first priority, is you have to establish an airway. Now, that little pitty in the video was still pink, could still move some air. Eventually they put a tube in because they had given him some anesthesia. Not all these cases will have to, but if the dog presents cyanotic, which, you know, they got that purpley blue color, then they're going to need to have an airway. I don't know if you could tell in the video, there was somebody while the mouth was open, someone was holding anesthetic tubing, and that was just providing what we call flow by oxygen. So a lot of times in these cases, we'll have somebody have like a hose or some tubing, so while the animal is breathing, we help give them oxygen. And again, even though these patients are in distress, sometimes they're very anxious. They can be snapping. They can sometimes be flailing. They may need sedation to get enough relaxation to get a tube in, or they need sedation just to purely calm them down, because, and a lot of times if you calm them down with sedation, they will actually breathe a little bit better because they're not as anxious. So they'll take a little bit slower, deeper breath. A lot of times they're going to potentially need some oxygen via nasal oxygen. Again, if you end up putting a tube in these dogs, they can't live with that tube in place. Okay, they're going to eventually need a plan. And a lot of times they're dehydrated, even though they can't pant, they're breathing with more effort. They're potentially losing more moisture. So sometimes dehydration and fluid therapy. You diagnose it. Now, I can tell you when a dog comes in, if it sounds like that, we're kind of thinking laryngeal paralysis, but obviously you need to do an airway exam. And so when we give propofol, I'll talk about in anesthesia how to give propofol. We normally do a half bolus, and you know, when you give propofol, a lot of times it causes a temporary apnea. It's a respiratory depressant. So when we give propofol in a laryngeal exam, we give a couple mils at a time. We give it much slower because we don't want to completely anesthetize them. We kind of want them, we want to be able to watch them breathe. If you blast them with propofol and they stop breathing, we can't watch them open and close their airway. So it's a light twilight kind of anesthesia that we do for a laryngeal exam. They should abduct completely. If they're abnormal, they're doing like this. They're not going like this. Okay. So, yes, Joey. Okay. Sorry. So how do we do this? When they present, a lot of times these dogs they have swelling from that stridor. So one of the first treatments is dexamethasone. I'm going to try to find that video. I show that video in anatomy. I don't know if some of you remember, it was a big chocolate lab and presented, and you know, very blue, gasping. I might try to email it to you guys just so you can watch that one. But the first thing they do is give him dexamethasone. Dexamethasone is a short-acting intravenous steroid. Prednisone is a longer-acting tablet form of a steroid, but they need relief. Dexamethasone is what we would give if something came in with like a bee sting, an anaphylactic reaction. And what's going to happen is it's going to reduce any edema. It's not going to make their laryngeal folds open and close, but what it's going to do is reduce that swelling, and a lot of times, and potentially sedation. So usually dexamethasone, sedation, oxygen administration, either by holding a hose in front of them or putting in nasal oxygen and hospitalizing. The only way to fix it is to do this laryngeal tie back. Think about like a curtain. If you had curtains in your house and you got old curtains, they have a little strip of fabric, and the fabric holds the curtains back. They tie back the curtains. Well, literally what you do, think of the laryngeal folds as curtains. Surgically, they'll make an approach, and they will literally surgically pull usually one back, and that will be permanent. So now that dog will always have one curtain pulled out of the way. We don't, sometimes I've heard of them doing two, but usually the reason we leave one normal is part of the laryngeal folds protect against them when they eat. Okay, they're supposed to close, and the epiglottis closes when they swallow food and water. If you permanently tie one back, okay, when they close, there's always an opening. So these guys are always going to be prone to potential aspiration pneumonia. And then so what we do with these guys, we feed them small, frequent meals instead of big meals, especially if you have a dog that like you feed him and they devour the bowl. My dog's kind of a grazer, so that would not be an issue for him. He just nibbles kind of throughout the day. But there are some dogs you put the food down and they just devour it. And if you have a dog like that, you're going to have to feed them because we don't want them eating a large amount of food. So it might be hand feeding. It might be soft food. If we're talking about post-op care on these guys, swelling of the airway is the number one thing. Typically, they're going to be in our hospital, strict observation, potentially, 2-3 days in the hospital. Quite often antibiotics are started because usually these guys have some underlying aspiration. Aspiration is going to cause a deeper lung issue, is going to cause pneumonia. So a lot of times these guys, because that is not protective normally, we're going to do antibiotics to cover bases. They're going to be on steroids to keep the swelling down. These guys, a harness is going to be key. We don't want anything pulling on the throat. Now, all of these are going to be potentially surgery or non-surgery. If the owner decides to not do surgery, this disease is progressive. They're not going to get better. It's more than likely going to get worse. So the owner needs to be aware of all of the nursing care. And the big thing I like to stress in my classes is nursing care, because I'm the one going in the room talking to them about all of this. How do you know your dog's in trouble? I talk about how to count a respiratory rate. I talk about how to look for effort. I talk about checking their gums, they should be bubble gum pink. They shouldn't be blue or purple. You don't want to assume the owner knows what to look for. You need to be very explicit. And then very restricted exercise. I would say even if you do the surgery and now that dog has more of an open airway, we still don't want to do a lot of exercise because their airway is not completely normal. Even if we fix it, there is still some degree of obstruction. So we have to be very, very cautious. So restricted exercise, understanding what we're looking for. We get into tracheal collapse. That's an upper airway disease, but now the larynx is normal. We're talking about behind. And remember, the trachea is fairly long, okay? So this collapse can be anywhere within the trachea. But it tends to be the toy breeds. I want to say like Yorkies are probably my number one on the list. Pomeranians, little Umfufu dogs. And it tends to happen as they get older. So it can be that owners notice this little bit of a cough when they get excited. And then as they get older, the more they get excited, the worse the cough gets. What happens is the tracheal rings start to lose their strength. That is the issue. Sometimes if a dog has Cushing's, that's going to affect the strength of the tracheal rings. Sometimes it's just a breed disposition. I mean, Yorkies are genetically predisposed to this disease. So if you look at what a normal trachea is supposed to look like, and this is from the anatomy book, it's a C-shaped. The top is a band of smooth muscle. Now remember, in excitement, fight and flight, that muscle relaxes to open up the trachea, and then it can adjust the opening of the trachea. But what's happening here, it's the cartilage. The cartilage is losing its strength. So it's not really a muscle issue. It's more a cartilage issue. If you look at these tracheas here, you see a nice shape. Do you see how this collapsed trachea is more flat? Now the muscle looks more bent here. That's because of the collapse in the cartilage. If we look here, and this is not a super great picture, but you've got a trachea here, here's collapsed, here's normal. Now, there are different degrees of collapse. There's where it almost looks completely flat. And then there's some where it's a little bit more open, okay? What these guys present with is typically exercise intolerance, respiratory distress, coughing. But the difference here is, and it's underneath on the notes page, it's more of a goose honking kind of cough. It's very distinct. So it's kind of hard to explain, but do you imagine some of those geese that are right outside the school, that it's a very different, and it tends to be more on exhalation. Tends to be the cough is more on exhalation. What we're going to do is an x-ray is usually enough to diagnose this disease. Now you can take a scope, an endoscope, and anesthetize the dog and pass it in the trachea and see it. There is also fluoroscopy. I don't know if you've learned about that in Rad 1. You're in Rad 1 now, right? I think you guys are. Fluoroscopy is a live type of imaging. Okay. And what you would do is you would have the dog under the fluoroscopy and you can watch everything moving live. Ultrasound is not going to be good for this. Okay. It's ultrasound, but fluoroscopy, if you have access to it, you'd have to go to like a specialty clinic. Now, here's a lateral thorax. Okay. If you follow the air-filled structure, now remember the esophagus follows the trachea, but the esophagus is muscular, and typically you're not going to see the esophagus super dilated. So what we're looking here, this is the trachea, and you can see all of a sudden here it gets narrow and then it opens back up. It's traced. Okay, let's look at another x-ray. Okay, this is very small. It should be probably 2 or 3 times that diameter. So that's a severe collapse. And in dogs, it's going to be different as how much is, sometimes there's a little spot collapse. Sometimes you have a bigger section collapsed. It's just going to depend on the dog. And obviously, if it's collapsed down here, this is more in the thorax. What we do for this, most of the time, tracheal collapse is going to be medical management. We need to put them on bronchodilators to try and open up any airway we can. Now, a bronchodilator is primarily working on the bronchus in the lungs, but it may offer some opening or relief for the animal. Cough suppressants are usually big because these guys are prone to coughing on exhalation, and sometimes the cough suppressants are going to relax those muscles and help them breathe better. And this disease causes inflammation, so some type of anti-inflammatory, whether it's going to be steroids, whether it's going to be non-steroidal anti-inflammatories. In the severe cases, you're probably always going to go for the regular steroids, which can go to the non-steroidals. The only thing, there is a surgical treatment, and it's a mesh. I'm going to show you on the next slide. But if you're going to post-op care, surgery, or if they presented with distresses, we watch them for 24 hours. Antibiotics in case we have some type of infection. A lot of times antibiotics are kind of thrown in the mix because sometimes these conditions with inflammation can predispose them to a secondary infection. And so a lot of times antibiotics are thrown in to just make sure we're not missing a bacterial component. Steroids, but the big thing on there that I want you to know is cage rest, exercise restrictions, harness. We don't want anything pulling on the neck. These guys, it's usually worse when they are excited. So we need to keep them calm. One case that we saw of a Yorkie that was pretty bad when it presented, the dog, when the doorbell rings, goes berserk. He goes all crazy, and then he would like pass out, because the more excited he gets, the more he's breathing and barking, the worse the collapse would be. And then he would get a lack of oxygen and he would pass out. So we need to keep these dogs typically also on some type of sedative. I would add that to a component, is they're going to be usually sedated, because when they're sedated, they breathe shorter and they breathe longer. Now, one of the, at the bottom here, sorry, the notes page is so big. One of the cough medications, butorphanol, which is a sedative I talk about in anesthesia, we use it in anesthesia, actually has cough suppressant properties. It's fairly expensive, but there are butorphanol tablets that you can send home. But a lot of times we'll write them a prescription for hydrocodone, and they just go to Walgreens and pick up hydrocodone syrup, just like we would take if we had a bad cough. So you may have to do that. Now, the surgical treatment that is listed is you can put in a mesh, it's like a wire cage. And this would go in almost like a stent in cardiovascular, but it would keep the trachea open. Now, because where the trachea is, if you do a thoracic, if it's in the thorax, you have to open up the chest. The trachea is very deep. If you have a dog on its back, when you open it, the trachea is going to be very deep. So this is not an easy surgery. The Yorkie that presented really bad, at that time, the only vet school close that would do it was the University of Pennsylvania. We're in Indianapolis. The dog could barely be out of oxygen. So she was trying to figure out a way to transport her dog, drive her dog from Indianapolis to Pennsylvania with an oxygen tank, sedated in the back seat, to go have this surgery. I think she eventually chose euthanasia because at that time, the surgery was going to be $4,000 to $5,000. It's not an easy surgery. So there is a surgical correction, but it definitely is not done everywhere. It takes a very specialized department and a very specialized surgeon to do this. So this is definitely an option, but most of the time, if they can't do the surgery, steroids, antibiotics, cage rest, harness, small feedings, keeping them calm. That little Yorkie was probably going to be on sedatives forever, something to just keep the dog relaxed. If it's due to some type of trauma, I want to say one of the big ones we see is what we call this big dog, little dog. In the ER, we call it BDLD. And it means that some little dog runs up to the big dog in the neighborhood. Big dog says, I ain't having it. I grab the dog, and often it's somewhere near the head and neck area, shake the dog and throw it. And a lot of times these dogs will present with small tears in the trachea. Well, the problem is any of that air that can get out of the trachea will sometimes get into the subcu tissues. So a lot of times when I see tracheal trauma, very rarely is it from a hit by car. It's typically when we get into dog fights. And especially if you see a dog fight, and if it's a shaggy dog, you got to clip them. Take all their hair off. I don't care what they look like. You have to look for punctures, and you have to make sure that if there's anything near the neck area, does it communicate to the trachea? Now, I'm getting broad here. You guys will get into, emergency stuff in ClinMed 5, but sometimes this dog is swollen, and it's called subcutaneous emphysema, because if they have a hole in their trachea, the air will escape into their skin, and you push them and they almost feel like bubble wrap, or it feels like Rice Krispies under the skin. It's very weird feeling, but what happens is you have to go in and you have to sew that trachea back together. We had a very bad trauma with a poodle present. We had intubated the dog. We were doing this surgery. We were trying to close the wounds. We were giving fluids. All of a sudden, the dog started coding. Pulse ox was dropping. This was very, very early. This was before I went to school, and I was working in a clinic just for extra hours. And then the doctor found a tear that we hadn't seen yet. So the problem is we were doing surgery to fix these other wounds, and there was a tear in the trachea, and that's why the oxygen of the patient was dropping, because we were intubated, but it was leaking around and leaking out of the patient. So pulse ox starts plummeting, and by the time we found it, the dog had passed. So it's very critical. Anytime there is a dog presents dyspneic trauma, you got to get a tube in and establish an airway. So that's the first thing. The other thing trauma can come from is intubation or extubation. When we do anesthesia, cat tubes, we typically put a wire in, and it's called a stylet, and it makes the tube more rigid. Cats are a little more difficult to intubate. So when we put this stylet in, if people do it wrong, it is like a wire stylet. The little wire end can go past the tube, and when it goes in the cat, it can cause a puncture to the trachea. There was a case, and I bring it up, where they were turning the cat during a dental. They had the cuff on the tube inflated, and it caused, when they flipped the cat, they didn't disconnect the endotracheal tube from the machine. And when they flipped it, it twisted the tube in the trachea, and it caused a tracheal tear. And the cat presented on emergency with that subcutaneous emphysema, and the cat had had a dental earlier that day. So that probably came from trauma during extubation or during the procedure. And then obviously we get these dogs that are potentially left in the backyard, abuse cases, and if that collar is too tight, and sometimes collars can migrate, that can cause trauma. So various reasons, dog fighting and such, is we cause any issue here, we're going to have a problem with the patient. Okay. Now, we're going to talk about lower airway disease. So everything I've talked about is this upper airway right here. We know the lower airway is anything that is contained within the lungs. So even technically the bifurcation of the trachea is part of the trachea. But once the trachea bifurcates and enters the lungs, these are diseases that are usually affecting the bronchioles or the alveolar sacs. And the alveolar sacs are where we have gas exchange. You know, right now, and this has been fascinating me because I love the respiratory system, anesthesia, pulse oximetry, ventilators, a lot of this coronavirus and issues that people are having in the hospital and these pneumonias is because this virus is affecting the lower airways. This virus is affecting the alveolar sacs. And what's happening is these patients that are presenting severe are not able to oxygenate properly. And what's happening is it's somewhere near the gas exchange mechanism in the alveolus. Because these patients are developing this pneumonia, but some are not developing a standard pneumonia. So there's a lot of research going on about what is this virus doing to our lungs. But the issue is typically at these very lower alveolar sacs. So when we get into lower airway disease, one thing to talk about is feline bronchial disease. And a lot of cats that present in respiratory distress, it tends to be this, and most people call it feline asthma. And sometimes there's bronchial disease and there's feline asthma. And, you know, people can refer to them as both. Sometimes it's allergy related. Sometimes this happens, say you sprayed something in the house, like an air freshener or a cleaner, and the cat inhaled it. It can induce this little asthma attack in cats. If they are outdoors, it can be an infectious cause if they get into, you know, especially if they encounter other cats. But sometimes we can't even get to the cause. You know, the owner might say they're not outdoors. Often they don't know if they're allergic to something, but if it happens at random times, then this is what you might see. What happens in these guys is that if a cat presents in respiratory distress, now I've said this before, a cat does not pant like a dog does. A dog will pant when they're excited, maybe when, you know, it's hot outside. Sometimes you give them a treat, they're like, you know, they're super excited. If I see a panting cat, I'm automatically concerned. Now, it can be stress. I will say sometimes a cat will come in and we'll get them out of the carrier, or we'll look in the carrier and they're panting. It could have been a hot car. It could have been the stress of the car ride. If it's for one of those two reasons, when you get the cat in the clinic, We usually take them in the back and we try to put them in a cage, or we try to observe them. It should go away. But if a cat was respiratory distressed at home and they come in, they're panting, it's a respiratory issue. These guys prolong, it's like a long inspiration, and it tends to be exaggerated. And sometimes you can hear a wheeze. But if you think about bronchial disease, usually the bronchioles are too small. Okay, so usually they're constricted. If they're trying to inhale, they're trying to pull air into these little airways. Sometimes they'll have a cough. It'll be like, and they're coughing sometimes after, but the wheezing, we have this prolonged inspiration, and when they exhale, you get the wheeze, because they're also now trying to exhale through these little tubes. So their bronchioles are constricted, and they're trying to breathe through that. So it can prolonged inspiration, wheezing, coughing, and sometimes the coughing gets so bad that the patient will vomit. And sometimes they also come in and they've got a lot of extra saliva, because all of that feeling makes them feel nauseous, and sometimes they'll have drooling, vomiting, especially after these problems. Now, what we can talk about is diagnosing. The first thing, because respiratory cardiac presents similar, is, try to make sure it's not a cardiac issue. X-ray is going to be one of the first things we're going to do in these cases. But I'm going to tell you right now, if you have a severe respiratory cat, you can kill it by taking an X-ray. If you have a cat that's in severe respiratory stress, a lot of times the doctor wants 3 X-rays. They want a right lateral, a VD, and a left lateral. But I'm going to tell you, a cat that can't breathe, and then you're going to try to restrain it to take an X-ray. First of all, they can lash out and try to bite you. Sometimes they're trying so hard to breathe, they're not focused on you, but a cat doesn't like to be stretched for an X-ray. And that stress is going to make this situation worse. I've done this in ER where we've ran down, because the cat was in oxygen, we throw them on the table, we take this kind of awful looking X-ray, we go back to oxygen, let the cat calm down, we go back, we take another X-ray, bring the cat back. So sometimes we'll do the X-rays in stages. But I'm telling you, I've seen people take X-rays and then this cat has been rushed down because it crashed in radiology. So, an X-ray is great as long as the cat can handle it. Blood work too. We want blood work. If you're trying to get a vein on this cat and they're freaking out because they can't breathe, it's not worth killing the cat to get a CBC chem. Now, the CBC is the best test because it's going to pick up any kind of like white blood cell inflammation. But often when we do a CBC, we usually do a chem too. But I'm going to tell you another tip. If you're drawing blood on a cat and it's stressing out and you can only get a little bit, your CBC is going to be your test that you're going to want to do first. Sometimes we don't get enough blood and we got to pick one or the other. And sometimes the cat is crashing and we have to stop drawing blood because we got to get it in oxygen. So at that point, we're like, you know what, let's just do a CBC. We'll draw blood later for chemistry. A couple other tests that are going to be helpful that are more specialized is you can do what's called a transtracheal lavage or bronchial alveolar. This is an interesting test because what we do is you can do this with a endoscope, but normally what we do is we give the cat some sedation, a little bit of anesthesia, light anesthesia. We intubate the cat. They place a catheter, a very small, like urinary catheter. We pass it down and we put a little bit of fluid, like about 5 mils or so of saline. Yes, we are putting saline in the lungs on purpose. What this should elicit, and we leave this hooked up to a big syringe. So we've got a long catheter, a big syringe. We push water in, and as the cat starts to cough, we suck out what the cat is coughing up through this catheter. So sometimes in the syringe, what you're hoping to do is get any deep, this can be good for a culture. This can be good to look for fungal organisms, potentially, you know, so those are kind of like the top things we do. But we do put, now we're not putting a lot of fluid in there because, yeah, we don't want to drown the lungs. We're putting a small amount of fluid. They're going to cough some of that up, and we're going to suck up what they're coughing up. And then we would send that to the lab. The rest of the saline will get absorbed, and eventually they will be fine. The other thing in cats is you talked about, hopefully you remember in parasitology or your Tech 2 class about lungworms. If this is a cat that it was a stray, if this is a cat that has an outdoor history or indoor outdoor, sometimes it's a late finding even in a cat that's been indoors, so it's kind of strange. But a lot of times, just doing a simple fecal. Obviously, that's not number one cat presents, let's get a poop sample. But I'm going to tell you, a lot of times these cats are in a carrier and they've defecated because they've been stressed. I would probably throw that little fecal matter in a baggie, stick it in your fridge, label it, because then if the doctor says, let's go ahead and run this fecal, you're like, well, I saved that stool from the carrier when the cat freaked out. So that's just a little extra tip. You can, you know, save that. It's probably going to be somewhere on your radars to get a fecal. Any treatment for this? Oh, you got to Zoom with Gillis. Okay, no, thank you for doing that. Sorry. I hate to back up onto other classes. I just like to give you guys a little break to not meet at 8. So let me stop there because I want to get into pneumonia in this. And my goal tomorrow will be to hopefully, we'll finish this up. We'll talk a little bit about review. I'll send you guys an email, and we will talk about our final. So I'll let you guys go. Yes, the homework is still due. Yes. Tomorrow. Okay.